afternoon, everyone. I welcome you on behalf of East Delhi Gynae Forum in our today's CME on Rh Isoimmunisation. This topic is a very pertinent topic, and it's a topic which is close to my heart. Because during our formative years in All India Institute of Medical Sciences, we have seen with our eyes the IUTs transforming the outcome of the babies which had been hydropic, severely anemic, and by an expert team which is there in All India Institute of Medical Sciences. And I've seen really indebted to our teachers, Dr. Dipika Deka ma'am, Dr. Alka Kripani ma'am, who have really instilled in us that Rh isoimmunization at all costs should be prevented. None of the women should get isoimmunized and come back with an ICT positive and leading into fetal anemia and hydrops. So this is our endeavor to prevent Rh isoimmunization. And in our today's CME, we have chief experts, Dr. Sharda Jain ma'am. She ma'am needs no introduction, and I will just say that ma'am is a Secretary General of Delhi Gynae Forum and is a keen academician and a teacher and a motivator to all of us. We have among us none other than Dr. Dipika Deka ma'am, who is a senior consultant at Apollo Cloud9 Hospital, Gurgaon. Ma'am has been instrumental in developing the fetal medicine department at All India Institute of Medical Sciences. And ma'am's work on IVIG along with an IUT is really path-breaking, basically, and it tremendously improved the fetal outcome. Welcome, Dipika ma'am.
Thank you.
Our first session, yes, ma'am. Our first session is a talk by Dr. Seema Gupta. The topic of the talk is the recent developments in prevention of Rh isoimmunization. We have chairpersons Dr. Jyoti Bhaskar and Dr. Vandana Gupta ma'am with us. Dr. Jyoti Bhaskar ma'am is a president of East Delhi Gynae Forum. She's a principal consultant at Apollo Cradle Hospital, Indirapuram. And Dr. Vandana Gupta ma'am, who is a vice president of East Delhi Gynae Forum. I request Dr. Vandana Gupta ma'am to please introduce Dr. Seema Gupta, our speaker.
Dr. Seema Gupta is a very esteemed member of our organization. She's director, RB Gupta Medical Center, treasurer, Delhi Gynae Forum East, and recipient of many awards. And she's a member of Society of Fetal Medicine and Delhi Gynae Endoscopic Society. So I invite Dr. Seema to start the deliberations.
Over to you, Dr. Seema. You can start sharing. You are muted, Dr. Seema. We can see the screen.
Not working.
It's working. Slides are moving.
It's going back.
Yes.
Yeah. Start.
Thank you, Dr. Sharda Jain ma'am, Dr. Dipika Deka, Dr. Jyoti Bhaskar, and Dr. Vandana ma'am. Today I'll be giving a brief overview of the recent developments in the prevention of Rh isoimmunization. Just to a definition of what is Rh isoimmunization. First, isoimmunization is production of antibodies in an individual in the response to an antigen derived from another individual of the same species. So Rh isoimmunization is basically when the mother produces antibodies in response to fetal RBC Rh antigen when she is herself Rh negative and the fetus is Rh positive. The main aim and objective of our management of any Rh negative mother is basically divided into two. If the mother is non-immunized, it's very good for us. It's basically prevention of alloimmunization. And unluckily, if she's immunized for Rh positive fetal cells, then the mainstay of treatment depends on early detection and adequate treatment of the fetal anemia. Since prevention is always better than cure, so anti-D is the mainstay of our management of any Rh negative women. If we see the how far have we come along in the prevention of this disease, in 1968, the approval was given for postpartum prophylaxis of Rh negative women. Even after 50 years of this approval, more than 50% of women around the world do not receive anti-D prophylaxis. This is mainly due to lack of awareness lack of availability and affordability. And this gap between the demand and supply is more in the low-income countries. So we still have an enormous burden of fetal and neonatal complications due to Rh-negative pregnancy. If we see the world scenario, the countries in red have more than 80% gap between the demand and supply. And our country, India, has around 50% gap still pending. So we need to do a lot of work in this regard. Anti-D prevents mother from forming antibodies against the Rh-positive blood cells of the fetus. The anti-D that we have available has evolved to a long time. Initially, we had the polyclonal anti-D. It switched over to monoclonal anti-D, and now we have the latest recombinant anti-D. The poly anti-D, which was initially it was anti-D produced by fractionation of IgG from the pooled plasma of Rh-negative men who were immunized with Rh positive red cells. So the resultant IgG that we got was polyclonal in nature. It was referred to as poly anti-D. Since it is made up of a mixture of antibodies, so there was a lot of limitations. It required human donors. There was a limited capacity of production, and there was always a risk of transmission of viral diseases. And also there was shortages due to lack of human donors which were there. So most of these limitations we tried to overcome with the introduction of monoclonal antibodies. The mono antibodies, as you see, they are highly specific against single antigenic epitope produced by a clone of single hybrid cells formed by fusion. A commercial preparation is available in our country also under the name of Proclone. The advantages of this mono anti-D is that it is specific, it is consistent, uniform, there is no batch-to-batch variation, and it is safe from transmission of viral diseases. However, this also has some limitations as there is difficulty in maintaining the hybridoma in a stable culture. Generation of these antibodies takes a long time, it is very laborious. And the main limitation was that the growth supplement that we required for the hybridoma, but that is the fetal bovine serum, is again in limited supply. So the production is again decreasing. If we see the comparison between the mono and the poly anti-D, the mono anti-D is highly efficacious. It is very specific. It has a longer half-life compared to the poly anti-D. It is purified. The risk of transmission of viral diseases is not there. The supply is more compared to the poly anti-D, but still the demand and supply gap is there. So to overcome all these limitations, we now have the recombinant anti-D. The recombinant anti-D is the hybridoma-derived antibodies formed by recombinant DNA. The antibodies are antibody genes from the hybridoma that we use for the monoclonal antibodies. These are isolated and introduced in the Chinese hamster ovarian cells. So these cells express the recombinant anti-D, which is harvested and used. To see for the efficacy and safety of this recombinant anti-D, a study was performed in Rh-negative women who never received any antenatal anti-D prophylaxis and who were ICT negative but with Rh positive babies. After the injection of anti-D, the ICT was performed and the samples were also collected to see for any antibodies that might have developed against the recombinant anti-D that was given. The study showed that the recombinant anti-D had similar efficacy in comparison to poly anti-D that we were already using. And also the safety data showed that the anti-D was well tolerated by the subjects compared to that of poly anti-D. The adverse events like pyrexia, abdominal pain, itching, and hypertension were not statistically significant. Also, the development of anti-drug antibodies, that is recombinant anti-D antibodies, were not seen in any of the samples that were collected. So to see that advantages of recombinant anti-D are not many. It obviates the need for fetal bovine serum. It is obtained from serum-free medium. So the risk of transmission of viral diseases is not there. We have a better yield, the supply is more, and it avoids the problem of cell line changes and mutations. So anti-D is a suitable alternative to the existing anti-D preparations available in the market. This is a graph. This is a picture showing how the recombinant antibody is manufactured. The human donor is immunized with Rh antigen, and the lymphocytes that produce antibody are then isolated, and they are fused with the myeloma cells. This hybridoma is then cultured, and then we get the monoclonal antibodies. However, if the genes from this hybridoma are isolated and they are injected into the Chinese hamster ovarian cells, and then they are grown, then we get the recombinant antibody, which is the latest in our basket. So to conclude, Rh isoimmunization is a real problem, and we all need to make efforts to mitigate this problem. The incidence has decreased dramatically, yet we still see many newborns with this problem, hemolytic disease. So every woman of childbearing age should have her ABO and Rh done at the first contact. Despite postpartum anti-D prophylaxis, there's always a risk of immunization in Rh negative mother in the sensitizing events that we will see in the following panel discussion. So the use of anti-D immunoprophylaxis in sensitizing events further reduces the risk of immunization. Awareness and availability of anti-D is the key to eradication of Rh immunization. Thank you so much.
So thank you, Dr. Seema. This is a very short, crisp talk and about telling us exactly about what the antibodies, anti-D that is available. So what I would just like to add over here, the importance of this particular webinar that we have been. In the last, I think, 4 to 5 months, under the guidance of Dr. Jain and Dr. Dipika, we have been raising 2-3 issues. One is the eradication of thalassemia major. And that is something that can be done, and we are really bringing it about and awareness to be able to do it. The second is the mission downs, about which Madam talked about yesterday, that it is again in our hands to be able to do it and to really prevent it. And I think the third thing that we really need to stress over here is that this is also preventable. That is, not a single child should be born because of the negligence or because of not being aware, because of the mother being Rh negative, and we have not. I think it's a very, very important and significant webinar that we are having today, just to make us all again aware how important it is to give the anti-D, not forget it, and to be able to tell us that yes, it is preventable and it is in our hands to be able to do that. So with that, and only one thing I would like to ask you is that for the benefit of all the people joined, which is the recombinant this anti-D that's available, and what is the cost of that?
Cost is around 2,700 MRP, something of the sort, and its name, anti-D is the name. Anti-D is the brand name.
Anti-D is the brand name, because Roclone is the monoclonal.
Roclone is the mono anti-D, and this is the anti-D is the brand name.
That's onto that. Right. Thank you so much, and
Good afternoon.
Hi, Dr. Gopal.